Welcome to AETCM, the emergency medicine channel. Shall I start? Present in the case of a 60-year-old male who came to ER with complaints of inability to retract the foreskin of his penis since the last 2 days, and now he has come with complaints of increased frequency of micturition and now increased pain during passage of urine since the last 3 hours. So on initial 10-second assessment, the patient was conscious oriented. He was.
How much was the age of the
60-year-old?
60-year-old. Okay, that's like aged person came with complaints of difficulty in retracting the foreskin.
Yes.
Okay. Anything in the systemic examination? Significant findings?
No, there was systemic examination. There was mild suprapubic tenderness.
No, I'm sorry. Primary examination.
Yeah, primary survey was fine. Yeah, it was fine.
Yeah, go on with your examination.
Yeah, so we had also after that we had taken as adjuncts. Adjuncts to the primary survey also was taken for this patient. In that the CBC CRP wise, the total counts was around 11,000 with a platelet of 1,60,000 and a CRP of 30. And on venous blood gas there was no presence of any acidosis. Creatinine was 1.3 and then sodium was 132.
Why
and
did you take the venous blood gas in this case?
So this patient had complaints of increased frequency of micturition. So and also like at the end he was complaining that he was passing very little urine. Okay. So we are having a doubt like whether he could be going on to a obstructive uropathy due to the bladder distension. Okay. So but the creatinine worsening was not there for this patient.
To check for the creatinine, you look for the VBG, right?
Yes, okay. yes. And following which we had taken the sample history of this patient. So this patient was a 60-year-old male. So he was actually having he's a known case of type 2 diabetes, and he's also a known case of CLD. So now he had come with the complaints of inability to retract the foreskin of his glans penis since the last 2 days, and with increased frequency of micturition and pain along the micturition, like along the meatus during micturition since the last 3 hours. So that was a main complaint. He also gives a history of fever since 1 day. There was no history of any abdominal pain, vomiting. There was no history of any loose stools, and there was no history of any like headache or giddiness. And the patient also gives a history since the last 1 hour. He's having a very reduced urine output coming out. So that was the complaint which he has presented. And we had checked the allergic history. The patient did not have any allergy to any non-drugs. And the medication history, the patient was on Udiliv. And was on metformin for diabetes. And so then we had asked him the past history. He's a known case of type 2 diabetes and CLD. So
any previous history of similar complaints?
The patient also gives a similar history of the previous complaints. It occurred around 2 years back.
2 years back.
Yes.
Similar complaints.
Yes. And
just 2 years back only. There was no any previous history in the like in the childhood during the once the age is progressed, there was no other histories. Just 2 years back he developed the complaints. Okay.
Yes.
Go on.
So this was then we also so this was the final. We came to a final diagnosis.
Local examination.
Yeah. So before that we reached the provisional diagnosis that the patient has a phimosis. That because he's having an inability to retract the foreskin. So then we had moved on to the systemic examination and the local examination.
So like you went on with the diagnosis of phimosis from the history itself. So what are the differential diagnoses that you can assess from this history itself?
Yes. So in this patient, the patient has an inability to retract the foreskin. It could be due to a physiological obesity. So if the patient due to obesity, there can be the presence of a hidden penis. So that foreskin will get completely swollen up, and we cannot see the penis, like the corona of the penis. So it can be presenting like a phimosis. We will not be able to retract the foreskin. That is one of the DD. The second one could be a penile edema, complete penile edema. So in such cases also it can be presented. Next one could be a presence of balanitis. So balanitis can also present in similar, prostatitis can also present with similar history. And then these are the main DDs which are involved. Then we should ask for a previous trauma history, whether we show if there's a previous trauma, there could be presence of scarring.
Scarring can be there. Then there can be like a genetic condition regarding the same. Then frenulum can also caused similar complaints.
Yes.
Then also paraphimosis sometimes can be like patient can say like if patient is having difficulty of which is not correct to the diagnosis can be like that also.
Yes. So in this patient, the systemic examination was within normal limits. The
So what do you mean by paraphimosis?
Yeah, so paraphimosis means the patient we are not able to relax back the retracted foreskin.
We are not able to push it backwards.
Okay.
So paraphimosis is a medical emergency where we have to do surgical correction if at all it's necessary, or else we can do with the medical or manual correction. If not necessary, you have to do surgical correction because of blood supply can be compromised.
Yes.
So here you got the diagnosis of phimosis. Go on with your local examination.
Yeah. So in the local examination of the penis, it was found that the penis around the tip of the corona was able to find. In that site, there was presence of a mild localized swelling with redness, but there was no presence of any active discharge from that site. And also, we were not able to retract back the foreskin, and there was no presence of any complete there was no presence of any band around the foreskin. So that also we looked up along, and there is no presence of any lesions or ulceration along the penis area. And we also checked for any swelling or along the scrotum or any pain along the scrotum. There was no presence of any pain or swelling along the scrotum. Along with there was no presence of any local rise of temperature or tenderness along the penis and the scrotum. So we came to a final diagnosis. It could be a paraphimosis. Phimosis. Yeah. So the phimosis was the final diagnosis which we came into. And initially we tried to manually correct the phimosis part, but we had tried twice. So initially what we tried was using a topical steroid cream. So that was the initial treatment which we tried. So along with a local anesthetic. So lignocaine along with the betamethasone 0.5% ointment we had applied, and we had tried to manually open up. So but we were not able to do so. Following which then we had to give a dorsal nerve block. So dorsal nerve block was given usually at the dorsal nerve of penis is usually at the 2 o'clock and the 10 o'clock position. So we had infiltrated local anesthetic without epinephrine, and following which we had tried to give a slit incision, and then we had to open up. So yeah, so with the help of a urologist. So we had also informed the urologist, and then we opened up. Then the patient was then admitted under urology. Yeah. So and at the end, the patient was undergone a circumcision.
Circumcision was done at the end. Okay, why did you give lignocaine as plain? Why not adrenaline was given along with it?
So these all arteries are like end arteries. So if we give epinephrine, then these all end arteries can completely vasoconstrict, thereby causing sudden necrosis along their side.
Okay.
So
to
that's
avoid
why
the necrosis, we give a plain lignocaine only in cases of any end appendageal blocks.
Yes.
Okay. So here the management is that initially we will try with the manual reduction with steroids and later on if at all it's not patient is not we are not able to retract it, then we will go on with the surgical management including initial slit and later on circumcision at a later date.
Yes.
So that is the thing that you have done here. So can you explain briefly regarding phimosis, types of phimosis?
Yes. So this phimosis is basically the inability to retract the foreskin from the glans penis. So that is the basic definition of phimosis. So the phimosis can be physiological or pathological. So the physiological phimosis is usually seen in infant or a young age, usually in individuals between within an age of 5 to 7 years. So after 5 to 7 years, the patient will be able to retract back the foreskin of the penis. So it will be within that age only. So usually the treatment or the manifestations mainly include the inability to retract back and can sometimes present with increased frequency of micturition is usually the presentation. And the treatment of physiological phimosis is usually reassurance, so that we can tell to their parents that within 5 to 7 years, the patient will be able to retract back the foreskin and to maintain good hygiene. So that to avoid urinary infections,
can be there in case
yeah, there is serious complications and gentle retraction during birthing. And that is usually the treatment in physiological phimosis. So pathological phimosis usually occurs when there is different causes. So it could be due to scarring. So mainly due to in case of a previous history of balanitis or balanoprostatitis history, or it could be due to a localized dermal condition like serotic obliterans. So that is one of the possibility. Another one is there could be presence of a tight fibrotic ring along the like between the junction. So corona. So the coronal sulcus. So in that area, if there is a tight ring, then we will not be able to retract back the foreskin. So that is another, that's a pathological condition. Then other recurrent UTIs. So recurrent urinary infections can also lead to this due to poor hygiene can also lead to this same condition. And then other DDs mainly involved, as I mentioned before, about the trauma or obesity. The penis can get hidden inside the foreskin.
Edema.
So, yeah, and even penile edema. So these involves a DD. And the presentation mainly involves the pain during urination or even pain during erection. So and even there can be recurrent balanitis history and recurrent UTI histories, and there can be urinary distraction symptoms. There will not be a proper stream of urine. The stream of urine will also be changed, and then there will be presence of so these are the usual presentations present. Or there could be presence of cracks along the corona of the penis.
Okay. So what might be the cause for the phimosis here in this case?
This patient previously gives a history of UTI also. So the patient is non-gastric type 2 diabetes. So maybe a chronic history of recurrent UTIs causing a previous balanitis could be one of the causing scarring. Could be one of the cause.
Another thing is patient is a CLD patient.
Yeah, CLD patient also.
Patient can have an edema also can be there because of the CLD and associated features.
Yes.
That can also attribute to the same. So here patient has been he had done circumcision and it's okay, no? Anything else you want to say?
The complications which are associated with phimosis. So the most important complication of phimosis is paraphimosis. So paraphimosis is actually a surgical emergency. That is the most important complication. Then the other complication involves urinary retention, or it could be like balanoprostatitis or recurrent UTI. So these are the complications involved. Treatment mainly involves application of topical steroids and even topical local anesthetic. Even it's not improving, then we'll have to go for a surgical correction. That can be done by circumcision or by a prepucioplasty. Yes. So these are the treatment.
Okay. Nothing more to know?
Yes.
Okay. Thank you.
Thank you.